Good afternoon for those who have attended or just joined us to this on this webinar. This is one of the first series that we have organized for the Singapore and Asia customers or clinicians. I want to thank you all for joining us today. My name is Kelvin. I'm the General Manager in charge of Asia for CardioScan. And we are hoping that this session and the sessions to come will actually help and provide that added value to what you do on a day-to-day basis. So without further ado, I want to really thank Singapore Heart Foundation. I think we've been talking to them on a regular basis, and we're delighted to have them partner with us in this session, as well as, of course, our none other than our Dr. Harry Mond. He's really an expert in this area. So we're really glad and delighted to be having him share with us today. And with his 49 plus or even 50 years of clinical practicing experience as a cardiologist, there's no better person, I guess, to share a topic like that. So without further ado, Dr. Harry, over to you.
Thank you, Kelvin. As Kelvin said, my name is Harry Mond. I live in Melbourne, Australia, and I'm delighted to have you spend your lunchtime with me. So we may be calling that in the future, Lunch with Harry. Today, I'd like to talk on the spectrum of ambulatory ECG monitoring. I have been a cardiologist for over 50 years, and I can remember back maybe 45 years ago when I first started reading Holter monitors, and I've watched the whole ambulatory ECG monitoring evolve over the years. And today there has been vast changes in recent years. And indeed, probably at the end of this talk, there'll be more changes, which I will not be aware of. Ambulatory ECG monitoring is a valuable investigative tool for patients with symptoms thought to be of cardiac origin. Historically, there are three methods of ambulatory ECG monitoring. There's the short term, which is the Holter monitor, generally 24 hours, but up to 48 hours, but today has been extended further. There is the medium term event monitors, which do not do continuous ECG monitoring, but rather only record events, and that can be up to 1 month. And finally, there's the long-term, maybe up to 3 years, implantable loop recorders. The way this is involved today, though, is that there is considerable overlap in these three, and in particular, the short-term Holter monitor has now become a medium-term form of monitoring as well. The basic indication for ambulatory ECG monitoring is arrhythmia recognition. The ACC/AHA guidelines, which are back as 1999, but are still relevant today, calls it class 1. That is, it's been proven that Holter monitoring or ambulatory ECG monitoring is useful for unexplained syncope, near syncope, or episodic dizziness, and in particular for unexplained recurrent palpitations. Let us look, therefore, at some of the indications, and as you can see here, it is basically arrhythmias we're looking for, and you can see a long list, and I'm not going to talk about all of these, of course, but only a small number. And the first, and by far the most important, is cardiac palpitations. Cardiac palpitations are the most common indication for ambulatory ECG monitoring. In almost all cases, a Holter monitor is the initial investigation even when the palpitations are infrequent, in the hope that they will capture an abnormality, even if asymptomatic. It's also the most common indication for medium-term event monitoring and is now becoming established for long-term implantable loop recorders. I'd like to stress, though, that a symptomatic negative test, that is, a test that shows no abnormalities, but if the patients are symptomatic with recurrent symptoms such as palpitations, the Holter or ambulatory ECG monitor is diagnostic and even therapeutic in that the patient can be reassured that there are no abnormalities. Here is some of the ECGs that we look at when we're doing monitoring. This is atrial fibrillation, and we in particular like to get the onset and the offset. Supraventricular tachycardia, once again, onset and offset. And here we have something that is very, very common in almost every case. We see a little run of a faster heart rate than the sinus rhythm. It's usually less than 100 beats per minute, and we call this a supraventricular run. It is of no consequence, no importance, but it must be differentiated from sinus arrhythmia. The important finding on a Holter monitor today are ventricular ectopics. If they occur in groupings such as bigeminy, trigeminy, couplets, we call this ventricular ectopy. Now, on this ECG, you can see single ventricular ectopics and then a group of three, which we call a triplet. Holter monitors are very important in diagnosing this, and we have to understand how to interpret the results, because ventricular ectopics are frequently asymptomatic. They occur at all ages. They're more common in the elderly, and on a routine ECG, it's approximately 1% in males. A Holter monitor, however, from 18 to 45-year-olds, it occurs in 41% of Holter monitors. And if you have an older group, then it is 73%. No structural heart disease, then it is very rare to have more than 100 per hour, which is 2,500 over a 24-hour period. It ranges from high burden and asymptomatic to low burden and very symptomatic. So some patients can have a huge number of ventricular ectopics and not feel them, whereas others might only have a handful but are very symptomatic with it. In the absence of heart disease, they are of low risk. Structural heart disease, though, is another matter because it's more sinister, particularly in regard to sudden cardiac death. We usually pick a figure of 24%, which we call high burden, that may lead to ectopic-mediated cardiomyopathy. That means the ventricular ectopics are involved in causing left ventricular dysfunction. This figure, of course, comes from the literature, but sometimes in certain vulnerable people, a much lower burden may be responsible, whereas in others, a much higher burden may not cause any cardiomyopathy at all. What is important, however, is that a cardiomyopathy is reversible following ablation of these ventricular ectopy. The next indication for ambulatory ECG monitoring is unexplained syncope or episodic dizziness. Generally, the Holter monitor has a low return, but unless, of course, the patient is having these turns very frequently. Irrespective, though, it is usually the initial investigation. And on the findings, as I will show you in a moment, asymptomatic features on the ECG may be clues that are very helpful. The medium-term event monitor is very valuable. However, there must be an automatic loop recorder for syncope. That I mean that the event monitor recognizes asystole or whatever other cause and will document it, because there's no value having a event monitor that you have to press the event button if you have syncope. And finally, long-term implantable loop recorders are very useful for infrequent syncope. Let's have a look at some of these cases where you see a clue on the Holter monitor. Here we have sinus arrest for 4.6 seconds. This is overnight, but it may give you a clue as to what is happening. Similarly, we have got complete heart block and ventricular standstill for 3 or 4 seconds. It too gives you a clue. Then another indication for ambulatory ECG monitoring are suspected slow heart rhythms. A Holter monitor provides a 24-hour window of heart rate changes. And you can correlate that to symptoms. And if you do have significant bradycardia, you may consider a pacemaker. If not, repeated studies may be indicated, whether it be 6 months or a year later. Clearly, medium and long-term monitors have no value in suspected slow heart rhythms. And the important one that's getting a lot of attention today is cryptogenic stroke evaluation, called neurocardiology or cardioneurology. Here, the neurologist plays a significant role in ordering these monitors. That is because 25% of ischemic strokes remain unexplained. A stroke of unknown cause is frequently due to silent paroxysmal atrial fibrillation, particularly in the elderly, and they will all require, of course, anticoagulation. A Holter monitor is valuable, but preferably multi-day. An event monitoring has very low return because the patients are asymptomatic. Although I must say that today companies are developing event monitors which can document atrial fibrillation. And then the implantable loop recorder, which is becoming very helpful in this group. Finally, I'd like to have a short word on non-arrhythmias. There are a list here of different reasons why we might order our ambulatory ECG monitoring in patients who do not have arrhythmias. Now, all of these have got software available within the monitors, but there is no established indications whatsoever for any of them. I would, however, like to mention one. It's ST segment analysis. Here we can have a look at a Holter monitor and we can see significant ST changes. Now, these are not unusual even in the young and in patients who have no symptoms. They don't usually mean myocardial ischemia. However, in the presence of chest pain, particularly if it's recurrent, you can see this, then this is essentially a positive exercise test and action must be taken. What about the hardware for ambulatory ECG monitoring? Well, the short-term Holter monitor was developed in the 1950s. It was suggested by Paul Dudley White, who was known as the father of cardiology, an American, and he suggested to a physicist, Jeff Holter in Montana, to develop such a machine. And you can see on the right where Jeff is got a Holter monitor on the back and he's on a bicycle. The early models were almost 40 kilogram. They had a radio transmitter and a receiver. And if you wanted to analyze the data, it took the same time as recording. So if you recorded for 6 hours, it took 6 hours to actually analyze it. A few years later, 1962 was the first commercial production, and these used small portable tape recorders. They were smaller, lighter, and most certainly quicker to analyze. And we could have 2 channels over, I say, about 10 hours of recording. Today, Holter monitors are inexpensive, non-invasive, and can be used more than once. Little evidence is that it's worthwhile on consecutive days. In other words, day 1 and day 2 are very similar, but they are very valuable if we can use them multi-day. We use 3 to 10 leads, digital recorder, and the data is recorded on memory cards or internal storage, which is downloaded and transmitted to a central workstation. We have today computerized algorithms for analysis, a high-speed playback, so it's very quick to do the reports, and then we also have commercial summary reports, which I'll show you in a moment. Electrodes may be generic, silver, and are inexpensive, replaced daily, and the quality depends on the quality of these electrodes. You, of course, require a cable which goes to the monitor. Here is a bunch of 24-hour Holter monitors. The top one on the left has 4 electrodes, to the right is 5 electrodes, and below is 7 and 8 electrodes. And today, however, we are developing new technologies able to record for longer than 24 hours, much more reliably. These use patches. These patches are all company specific. They are expensive, but because of the quality of the tracings and the lack of need to do them again, they are probably cost effective. The monitor is clipped on to the patch. They are high quality recordings. And as we are developing them, you can use them now in the shower or even with swimming. Here is the one by MyPatch and that CardioScan uses. There are a number of other ones. This one is particularly good because it's small, it's very comfortable. The patch, which has gone through many iterations, is now very reliable, lightweight, 2 or 3 channels, rechargeable battery, again, shower or swim proof, a genetic software, no memory card, and you can use it for up to from 1 day or up to maybe even 14 days. Let's have a look at the summary reports for Holter monitors. For instance, this is a 19-year-old male with palpitations during exertion. This is the report. You can see the name and address at the top, the age, the heart rates, and then we have a supraventricular tachycardia. This is a snapshot of those rhythms that occurred during supraventricular tachycardia, and then we have a final report at the bottom of the tracing. This is page 2, which gives us an enormous amount of detail. At the top, we have the time, and then we have the heart rate histogram. And you can see that the patient woke up at 6 a.m. and was jogging. Later on, with the onset of a supraventricular tachycardia on top of this sinus tachycardia. And this is well documented on the report here, the time it occurred and the number of beats. And then the offset is also recorded. Here is a 12-lead Holter monitor. In the 7 or 10 electrode Holter monitors, we are able to create a 12 lead, which is particularly important for physicians who are evaluating ventricular ectopics as to the site of where they come from in order to try and ablate them. And we have a 7-day Holter. It showed 5 days here, but this shows over 7 days we can have a Holter report. We also said that there are medium-term event monitors. These are simple, leadless, patient-actuated event recorders. There is also a memory loop recorder so that it can recognize an arrhythmia. And also, when you press the button, it can retain 30 to 60 seconds before triggering. The recorder has memory, and it can be partitioned for both patient-triggered and also auto-triggered arrhythmia recognition. That means the patient might have very frequent pressing of the button, but we have a partition that allows it also for auto-triggering. They are generally prescription items, meaning that they are asked for by a physician. Generally, these are single channel. Maybe multi-channel will become available. Now with increasing memory storage, we can do a lot more with them. The automatic arrhythmia recognition is bradycardia, tachycardia, atrial fibrillation. The data is sent to the clinic via the memory card or USB port or via acoustic coupler. For instance, this is the one that stood the test of time for more than 20 years, the King of Hearts. Instrumetics was the company, had 2 built-in electrodes and a bradycardia, tachycardia triggers and an atrial fibrillation triggers in later models. It's not manufactured anymore. Here is another one showing where you can place the 4 electrodes onto the chest and obtain and press a button, which you can see there on the left-hand side, start, or it can be attached to electrodes. And finally, the Zeo patch, which is a patch as well as an event recorder, and it's particularly useful for atrial fibrillation evaluation. It can last for 14 days. It's water resistant. There is a symptom button. It's mailed back to the central analysis office, and you can see it's a disposable unit. There are non-prescription ECG monitoring available today, and I think most of you are fully aware of these. It's commenced with numerous heart rate monitors that were linked to smartphones and apps. Now it's been extended to the ECG rhythm strips, usually 1 lead though, which is limited. It has, though, unlimited technologies that can be put in phone covers, watches, pens. Let's have a look at the number of these. Here is a phone cover. If you put your fingers on the back of a phone, you'll get an ECG. Here is another one, which is linked to a watch and also can go to a phone with adapters. You place your fingers over the electrodes and you can obtain an ECG. It also is useful for atrial fibrillation detection. Heart Check, a Canadian company, you put your fingers or thumbs on this and you can do very frequent downloads and you can transmit via the internet. And we all are aware of the Apple Watch. I believe it's a Series 4 onwards, which still has somewhat limited approval. It's now available in Singapore and Australia. You require a software update in the phone, And the trial showed that it does recognize atrial fibrillation, but the confusion with artifact is quite pronounced and in fact may cause more headaches for the physician than what it's worth. Finally, I'd like to just show you the implantable loop recorders, which last for 2 to 3 years. 3 companies currently manufacture them. They are inserted almost via a syringe type, and it's also now got emphasis on atrial fibrillation detection. Very successful, but of course expensive and invasive. So ambulatory ECG monitoring is a valuable investigative tool for patients with symptomatic symptoms thought to be of cardiac origin. Thank you. If you'd like to ask questions, I'll be delighted to answer. Thank you.
All right. If there's any questions, you could either raise your hand or you could type it in the question and answer box. And I think we have 2 questions. One is, if you could do a 14-day 3-channel Holter patient on a stroke Holter on a stroke patient, why would you implant a LR?
I said that as well. It's invasive and it's expensive. A Holter monitor probably is the way to go for 14 days, and it's quite very successful in that. So this is how the Zeo has been designed, as well as the one that we use in CardioScan. And I think both of them are very successful. And in certain research institutes, there is definitely they would like to use the implantable device, but we really are not sure how much more valuable this might be over 2 years.
Right. We've got one more question coming in. Why would you do a 7-day event monitor if you could do a 3-channel Holter monitoring for the same time? Well, this is valid.
Well, it's similar question, similar answer, in that the 14-day Holter monitor, as we know it today, is a very successful way of monitoring patients. It can be either 2 or 3-channel. Remember that you need an extra electrode for a 3-channel device, and that therefore we go for just a 2-channel. A 2-channel is far superior to any 1-channel. Having had a lifetime of experience with artifact, and one day I'd like to give you a whole hour lecture on how to look at artifact. This I find to be very frustrating, and having a 2-channel device makes it much easier and probably much more reliable.
Right. Thank you, Dr. Harry. One more question. How accurate is the ECG via the phone cover if a person with a poor peripheral circulation?
I don't know. I have no experience with any of these. I showed them out of interest, and you are correct. You would not use this on an elderly person with a tremor and poor circulation. There'd be no value for it. But remember, there are a lot of young people out there with palpitations, and therefore it's good business.
Right. Same person asked also, how many channels for the Zeo patch? Do you know?
I think it's only 1. Again, I've had no experience, but if you look at it structurally, it could only be 1.
Right. Okay. And we have one more coming in. If someone has ST depression with no symptoms of chest pain, giddiness, etc., is it fine?
Yes. Yes, it's a good question. It's a very good question, because I have looked at these quite frequently, and we're never told if the patient's got chest pain at that time. So some physicians find it difficult to arrange an exercise test, and the patient is not well enough to get up onto a treadmill or a bike. And therefore, if you can organize a Holter monitor, as long as you're careful in telling people what you're looking for, you may find it very helpful.
Right.
The same thing with coronary artery spasm. You can find that you can try and induce the spasm with exercise tests, and it doesn't work. However, if you do a multi-day Holter monitor, you may see very, very dramatic results and confirming coronary artery spasm.
Right. Thank you. Okay. One last one here. As a follow-up, is there a future for event monitors?
It depends. See, that's why my first slide almost said that they are evolving, one is evolving into the other. However, I strongly support a proper ECG 2-channel over the full time rather than an event monitor, as you are not sure if the software is going to pick up the abnormality. And of course, it's not always reliable with the patient. Cardioscan used to use event monitors. It was the most frustrating experience of my life, in that we would go through maybe hundreds of tracings with just artifact. So it's not particularly valuable. Today, we're getting better results, but of course, we need to have things like patches in order to exclude the artifact.
Thank you. Two more. One question is, the Holter report also reports heart rate variability data. How do we apply this information to our patients?
You don't. As I said, heart rate variability is something that I've never got a handle on. I've read many articles on it, trying to understand it. And the moment I finish the article, I have forgotten. In other words, I don't really put much emphasis on heart rate variability. And the problem with Holter monitors is that you probably require a perfect monitor for the 24 hours in order to be able to apply it. So as I said, in some institutions, it is a research tool, but I am unaware of anybody who uses it in general practice, unless they're a very esoteric group of people.
Okay, right. One last one here in the Q&A column. What is the incremental yield for AF as you increase monitoring from 3 to 7 to 14 days to ILR prolonged monitoring?
Good question, and I'm not sure I really have an accurate answer. I can't give you figures. I've read many articles, but of course they're all different percentages. So I can just make up a percentage, and I know I won't be wrong. But if you go from 1 to 2 days, it's not very valuable at all. If you go to 7 days, it becomes much more valuable, and 14 days is very valuable. Cardioscan is, I believe, doing a study in the United Kingdom looking at our results in patients who have been referred with atrial fibrillation, and we are getting interesting and good results. However, the other alternative is to have an implanted device, and I would think that this may well give you more data over 2 to 3 years, but how relevant it is, I don't know. I look after a large groups of patients with pacemakers, and I can tell you that as you get older, 80, 90 years of age, the incidence of atrial fibrillation is extremely common in these groups of people. And we look at them on a year-to-year basis, and you can always find 1 or 2 episodes of atrial fibrillation. And the question remains whether we should be using anticoagulants in these group of people, 80, 90-year-old, frail, fall over. And I'm often left with the dilemma of finding what appears to be atrial fibrillation and in these elderly. It's much more important, of course, in the younger person, if they do have a stroke, to be able to recognize it and start anticoagulants. And I would think that a 14-day halter would probably be as good as an implanted event monitor.
Right. Yeah, and we could definitely send you more data as we get them, for the question, Evelyn Lee, and if you want, or any other participants who want more data on that, once we've finalized them, we're more than happy to send you more information on that as well. One more question coming in. The 3 leads on cardioscan, which lead are they equivalent on the 12-lead ECG? Somebody asked.
When you do a Holter monitor using separate electrodes, there are a number of different combinations. The one we use at Cardioscan is usually the V leads, with the middle one being V1, which is very important if you've got a bundle branch block and you want to know if it's left or right. However, the patch is not as sophisticated as that. It can't, because it's all narrow. And I actually have looked at the leads, and I actually got a slide of it, but I can't tell you exactly. But I don't. But it's if I believe it's not V1 at all in any of them.
Right. Thank you. Any other questions? You could either send them in now or feel free to email me. I think from the invite you will have my email address. If you do have any questions for Dr. Harrimond, feel free to email me at as and when required. If there are no other questions, I really want to thank you guys for coming on board to attending this session, as well as of course Dr. Harrimond. Thank you so much, Dr. Harry, for helping us understand this topic that has always been bugging me. And also, I think we want to thank Singapore Heart Foundation for helping us with this promoting this session together as well. So without any delay, I know some of you need to go back to the clinic and your wards. Thank you very much, and stay tuned. We will be sending you more information on more webinars such as this in the next couple of months. Stay tuned. Thank you, and see you soon. Bye-bye.